I honestly can't say if every man in here has eaten it. I really can't say. About sparrow saltfish. That's what I'm talking about. But Sparrow said it all, saltfish is sweet. And therefore, we're going to be speaking to Dr. Anthony Pottinger. I don't know if it's about saltfish or the vagina, but the medical expert is here to talk about the vagina. When we had the last conversation, we paid a lot to, looking at, infections, what really is the vagina, how it works and all of that. But right before we closed, Dr. Anthony Pottinger was talking to us about HPVs and, cervical cancer and just where that came from. So we're going to continue the discussion from that angle because a lot of women suffer with cervical cancer, and Doc could attest to the fact about how many surgeries he's done to try to correct this. Good morning to you, Dr. Pottinger, and welcome back to the Now Morning Show.
Good morning, Natalie. Thanks for inviting me again.
Yeah, well, it's by popular demand, by the way. I didn't realize that the vagina was such a popular thing. I didn't realize.
Well, technically speaking, the cervix is different from the vagina.
Right.
And the vulva is different from the vagina. Last week, we didn't get to deal with the vulva so much.
Yeah.
So I wanted to talk about the vulva this morning. But since you mentioned about cervical cancer, which is definitely the most important part of this thing.
Yeah.
So cervical cancer is second only to breast cancer in killing women in Trinidad from cancers. And this is crazy because this is almost 100% preventable. Now we know that almost all cervical cancer is due to a persistent infection with a virus called the human papilloma virus. There's over 100 of these viruses discovered so far, and 30 of them infect the genitoanal region. 14 of those can cause cancers. Over 90% of the cancer due to only 4 viruses: HPV 16, 18, 45, 31. The next 3 is 33, 35, 52, and 58, and they're related. So 18 and 45 are like first cousins, and 16, 35, 30, 31, 58, all of those are related. So everybody must be assumed that you have been exposed to HPV once you're sexually active, right? So I have nothing people like to say, well, like is promiscuous women get it. It's stupidness. Once you ever had intercourse, you could have it. You could have it from your first sexual contact. The thing is, everybody will get it, but not everybody can clear it. So you find some people end up with a persistent HPV infection, and that is the problem. So if you have a persistent HPV infection, it could take 10 years, 20 years, 30, it could take 40 years to cause the cancer. This is what a virus do. It eventually causes a malignant transformation. So by 3 years after becoming sexually active, every woman should start doing something called a pap smear. Pap smear has been around nearly 60, 70 years now. Simple test just to collect some cells from the mouth of the womb, which is called the cervix, the external os, put it on a slide, fix it, send it off to a cytoscreen or a pathologist. They will then stain it with certain stain we call a Papa Nicolau stain and examine it on a microscope at about 400 times magnification, looking for either the telltale sign of the virus or the changes, what we call dysplastic or dyskaryotic changes, mean the cancer type changes, right? And if that is there on this slide, then you get a pap smear. A report might be saying you have, in the olden days, they might say you have CIN1, 2, or 3, or you might say mild dysplasia or mild dyskaryosis, or moderate or severe dysplasia or dyskaryosis. Nowadays, the terms uses the low-grade squamous intraepithelial lesion, and that translates to what we used to call CIN1, mild or moderate dysplasia or dyskaryosis. CIN2 or 3, it used to be moderate or severe. Those lumped together now and are called high-grade squamous intraepithelial lesion. So if you have a pap smear saying you have a low-grade squamous intraepithelial lesion, it's good. It's not a precancer lesion. That is like just an inflammatory response to the presence of the virus, and left without any treatment, 99% of the time, you will eventually clear that. So you don't have to go chasing around, burning, freezing, cutting away. And that is happening in Trinidad every day. For mild dysplasia or low-grade squamous intraepithelial lesion, some people still feel the need to treat, and it don't need to be treated. Okay? If you have a high-grade squamous intraepithelial lesion, ideally you should be sent to a gynecologist who have a colposcope, who understand colposcopy, and they will then the colposcope is a microscope that you can watch the cervix at magnification. So you watch the cervix at magnification naturally first, then you clean it with certain things. Watch it again, you could paint it with certain things, 5% acetic acid or something called Lugol's iodine, and under the microscope at 5, 10, 15 times magnification, you look for certain features that indicates that we have CIN2 or CIN3. CIN means cervical intraepithelial neoplasia. So all surfaces called epithelium are mucosa. All epithelium is on a foundation, like the top of the table, called the basement membrane. The cancer cells will be on top of the table if it's a precancer, what we call CIN1, 2, or 3. But the pap smear only scrape off what is on top of the table. It can't tell you what down below in the jaw. So when you do, if the pap smear suggests a high-grade lesion, you colposcope and you see certain features, what we call punctation, mosaicism, etc., acetowhite epithelium that indicates something is going on. Ideally, you should just give local anesthetic to the cervix and remove the abnormal piece with something called a loop excision biopsy.
So that can be done with a regular
visit? Right, in the office. Most gynecologists not set up to do it. But those who deal with cancer, the gynecologists and them, we have everything. I do all of this in my office. It could be it's a one-stop. So you remove it, send it off to the pathologist, and the pathologist will now tell us if the dysplasia, dyskaryosis, or what is called the cancer cells, the surface of the epithelium or the cervix and the vagina is covered with what we call squamous epithelium, and it's like about 15 generations of cells thick, and you divide it in thirds. So if the bottom 1/3, this is the basement membrane, if the bottom 1/3 of the cancer cells, that is CIN1, cervical intraepithelial neoplasia grade 1, I tell you this is not a real precancer lesion. Most of the time it will not progress. If it come up to 2/3 is CIN2, and if it come up to the last layer is CIN3. Now CIN3 left without any management, we believe at around 30 to about 50% of the time it will eventually break through the top of the table.
Right.
So if you have CIN3, mean all of the thickness of the epithelium of the cancer cells, it can't go anywhere. The epithelium don't have no lymphatic channels, no blood vessels or anything. It can't go in, it can't do nothing. Okay? But eventually, if it erodes through the top of the table, which is the basement membrane, below the table you have lymphatic channels and blood vessels that it could invade into them and then disseminate. And that is what we call an invasive cancer. We don't want that. All right? That's very difficult to treat, very expensive, and it will still bust some people through it. So people, please start doing your pap smear by 3 years after becoming sexually active. If the first 2 or 3 annual ones are normal, you can do it every 3 years, up to around 50. If all of them have been normal, you probably could drop it to around every 5 years.
When you talk about...
last time we mentioned that the policy is to stop doing the pap smear screen at 65. That is not a good policy, all right? I've seen many women in their 70s and 80s and 90s with invasive cancer. You should continue to do the pap smear screening for the rest of your life.
So if you're talking about how the propensity to get HPV, the human papilloma virus, and that this being sustained in the body as an infection, what can women do to safeguard against that? All
right, so as I said before, do your pap smear. So if you have the virus, even if you can't clear it, as long as the pap smear remains normal, you're all right. Because the pap smear will pick up the precancer, should pick up the precancer stages, all right? Before it break through the bottom of the table, if you do it at least every 3 years, okay? You're going to have false negative, so the pathologist might say, no, it is normal when it's not normal, but if you do it again in 3 years' time, you most likely will pick it up because it's a slow process. You're not going to drop off a precipice. And there are vaccines now available, about the last 20 years, right? 2 of them available in Trinidad, 1 privately and 1 publicly. Access the vaccine. So everybody, all women, initially when they bring it out here, they were saying that it's only virgin girls between 10 and 12. It's nonsense, right? The gardasil that the government bring in, the studies go up to 45 years. And even women at 45 years, if they get the vaccine according to schedule, mean you get one now, the next one 2 months' time, and the last one 4 months after the second one. They will seroconvert, mean produce antibodies, and will produce antibodies at a high enough level that it will protect you going forward.
Would they recommend the vaccine even if you're already exposed to the HPV?
Yes, exactly. Because this virus don't go into the bloodstream and go all over your body, like say measles, mumps, rubella, chickenpox, or anything like that. This virus stay in the mucosa. So it is there in the mucosa, the vagina, the anus, probably your mouth or the cervix and thing, and the whole life cycle of the virus is in the mucosa. It don't go in the bloodstream, so it don't get exposed to what we call the reticular endothelial system or the immune system. So you know, develop no memory for it. So people could get it, and it's a localized like inflammatory response what we call innate immunity, that clear it, but you don't develop any memory. The memory is what we call humoral immunity. So if you don't develop any memory, you could get it 100 times, clear it 100 times, and you're still susceptible. Yeah. Now the immune system is at the zenith in adolescence. After about age 15, it's downhill for the rest of our life. So somebody who used to clear it in their teenage years and their 20s and their 30s might reach 40, 50, 60 going on the road, get the same virus again, and the immune system weaken to the point where you can't clear it. So you end up with a persistent infection. And if you're negligent and not doing your pap smear, we won't pick up things when it's easy to treat, and you present with invasive cancer. And people walk into my office all the time, postcoital bleeding, postmenopausal bleeding, or intermenstrual bleeding, offensive bloody stinky discharge, and them have the big invasive cancer there. Never did a pap smear. That is craziness in this day and age.
So it's critical that as women, as you said, 3 years after becoming sexually active, get those pap smears done.
And access the vaccine.
How often do they recommend you get the pap smears done? Is there a difference based on what's happening with you?
Well,
in terms of the time frame?
As I said, for the normal person, if the first 2 annual ones normal, do it every 3 years. Okay? Say, for instance, you get a pap smear that say you have a high-grade lesion, high-grade squamous interepithelial. You have the colposcopy, it show features. We do the loop biopsy, and you have CIN2 or CIN3. That person critical, they have to be vaccinated because their immune system telling us it can't deal with the virus to the point where you have a serious precancer lesion. So they have to get vaccinated, whichever one available. So you get vaccinated, that will now help your immune system to produce antibodies and memory cells that if the virus show up again, you will recognize it. The memory cells become something called a plasma cell, boost the antibody response and protect you. Okay, now somebody like that who have CIN2 or 3, you follow them up at 6 months, I will do it again. If that one normal, you do it 6 months after that, which will be 1 year from the time you did the loop. If that normal, do it annually to 5 years. If all of them up to 5 years normal, they can return to 3 yearly, especially if they were vaccinated.
Doc, we only have 3 minutes left.
All right,
you wanted to
talk
about the vulva.
Clitoris.
Oh, the clitoris. All right.
The clitoris is a organ that we don't really know much about. Yeah. Well, most people, they know it's a little knob, they call it the PIM or whatever, and thing, I know that it's sensitive and it gives pleasure. But the clitoris is like, it is the only organ that we have in our body that the only sole purpose is to give you pleasure. All right, everything else have some other function. The clitoris is there just to give pleasure. No, it's not just the little knob that we see there. The little knob that we see is equivalent to like the head of my penis. They call it a glans penis. So that is what you see. But then the clitoris have a shaft behind, and then it can be anywhere between, say, a centimeter up to about 2 to 3 centimeters. Some people have a bigger clitoris, especially the girls who have the polycystic ovarian syndrome. We will start about that some other time, okay?
Oh, so the size of the clitoris can tell you something about polycystic ovaries?
Well, more polycystic ovaries manifests itself in some people getting what we call clitoromegaly. Because the polycystic ovaries, the ovaries are bigger than normal ovaries, and they over-secrete testosterone, the androgen, male hormone.
So if I'm a woman and I see that my clitoris has changed the size or looking bigger than usual, should I automatically get a gynecologist
Not necessarily, because the syndrome of other things. You'll probably be missing your period, having no period. You might have acne, you might have mustache and beard, pubic hair go up to the navel. Most of the people get overweight, particularly central obesity. So it's just part of a syndrome means a constellation of things. But the point I want to make this morning is that the clitoris is much, much more than that little thing that you could see there. So just like my penis, the same things that might form the penis form a whole, is like a clitoral complex. Yeah. So that little piece what you see there is just the tip of the iceberg. So you have 2 things what they call the crust that pass backwards around the urethra. The urethra is the hole that the urine come out, and around the vagina, and it come and then fuse at the perineal body just in front of the anus and behind it, right? So it is a big thing, but we like the so-called G-spot, Grafenberg spot. Dr. Grafenberg described this spot, which is supposed to be on the anterior vaginal wall, very sensitive. And if stimulated, that will increase the woman's chance of having orgasm. But that is just part of the whole clitoral complex. So if you're looking for a structure called the G-spot, it now is a physiological thing that have 4,000 sensory nerve. And if stimulated, get engorged Once if the one excited, get engorged, and they probably could feel it. But in the resting phase, you're not going to feel anything. But it's just part of the whole clitoral complex. So the clitoris is not that little knob you see there. It's something just as big as the man's penis. Because all the structures that make up the penis make up part of the whole clitoral complex. When the woman gets excited, it gets erect. And just like with the penis, so it have erectile tissue, and you might see the little knob get bigger, but
right.
you're not seeing the much larger
So when somebody
picture.
is doing a sex change, is that what, is that is it an organ that they use to, you know, to do that sex change when you're going from female to male?
If you're going from, you can't, it's hard to go from female to male because it's hard to produce a proper functioning penis, right? But it's easier to go from male to female because you're removing penis and the parts and you're creating a passage to simulate the vagina and things and so. But this is not in my area, so I don't want to talk too much to see. I can't really tell you how much sensation somebody would get from an artificially made vagina, right? Because we can't really all the nerve supply and the blood supply that you need in this clitoral complex. I don't know if we can just simply, you know, use some skin and some muscle and, you know, reproduce it, right? But the point I want to make is that no such thing as a vaginal orgasm as such. Almost all it is really 90% of sex is in your head, and then they have the sensory organs, of which the king of the forest is the clitoris, right? 8,000, like last time I said, 8,000 sensory nerve, while the penis only have 4,000, right? Somebody curry favor towards all your women, right? And the anterior vaginal wall, the so-called G-spot, have 4,000. So it is important to people understand that if you stimulate the urethra or the vagina or even the anus, you stimulate the clitoris because it's the same clitoral complex. And by stimulating the clitoris, you might get good feelings around the urethra, the vagina, and the anus.
All right, Doc, I want to thank you so much. So now we definitely should have a better understanding of the whole female reproductive organ. Because as they say, what we call in the vagina is the vulva. What we're talking about, you know, pleasure from the vagina is really from the clitoris. So Dr. Pottinger, we appreciate you. Thank you so much. Stay tuned next week on Your Body and You. Who knows what body part we'll be exploring. We take a break and we'll be back.
All right.
I like the taste.